Prostate Forum of Orange County. Before I get started, I'd like to make a few announcements. Some of you may have already heard, but for those of you that have not, a new weapon against prostate cancer was approved by the FDA this week. It's called Exofigo. What the heck is Exofigo? Well, you may have known it by alpha-radon or radon 223. It seems like every time the FDA approves a new medication, they started out with a new name that starts with X or Y or Z. For instance, what was wrong with abiraterone, which is now called Zytiga? What was wrong with denosumab, which is now Xgeva? What was wrong with MDV 3100, which is now Xtandi? Well, one that's not quite approved yet for prostate cancer, ipilimumab, and that's hard enough to say, so they converted to Yervoy, and I'll go along with that. That's a good deal. So anyway, this is the little trick that the FDA does. It's Exofiga, and what it is, it's a radiation treatment, injectable radiation treatment, that zaps any of us that have bone metastasis. It's something I've been looking forward to a long time, since I have stage 4 prostate cancer. And now we have a good weapon against bone metastasis. This is a radioactive injectable agent that goes directly to the lesions in the bone and kills them. Because it was just approved, it will probably take weeks and maybe even months to become readily available, because they have to boot up the supplies and get them to distribute it and get the insurance approvals, et cetera, that all goes into this. But it is FDA approved. For those of you new to our meetings, prostate cancer patients and their wives need to know where the bathrooms are. So if you go out the door to the back and to the right, both the ladies and the men's restroom are out there. Prostate Forum of Orange County is looking for short-term help. So if you have any specialties that you might be able to contribute, we'd sure look forward to it. We're looking for things like somebody to investigate grants, because everybody always needs more money to do the better things that we do. Prospective public advertising avenues, and anything else in your background knowledge would contribute to the Prostate Forum. Also, the prostate cancer is a family issue. And if there are any women out there that would like to contribute by helping us further with our cause, see me or a board member, any of the board members, and we'll talk about it. We started our women's support group, as I mentioned already today, and it's off to a successful start, I think, with 5 attendees. Not very many people know about it. You have to read the prostate cancer bulletin to know that it was going on, or have word of mouth. And not too many of the ladies out there are reading the prostate cancer bulletin. They will meet the 4th Thursday of every month, the same as we meet. They'll be meeting. It was scheduled for 6:30. Steve here? Steve just, Steve. It was scheduled for 6:30 today. Is that going to be the normal time for the meeting?
I think for right now, yes.
For right now, okay. It barely gives them time if they want to come in here, but maybe they don't want to come in here. So, anyway, thank you, ladies. They're not here right now for me to say thank you, but thank you, ladies. We do have to support the expenses of our work, and if you could help, we would appreciate it. We get about half of our expenses from your generous donations, and the rest from the donations from the local community. I'd like to have a couple of our board members here pass the baskets. Let's see what in the baskets. Oh, there they are, yeah. And in addition, while they're doing this, I'd like to have the board members that are in the room that are present, please stand up so that we can acknowledge who you are. Don't be shy, John Olson, stand up. Okay, I think that's the board members that are present. These are the people that give selflessly, without compensation, of their time to provide you with the help and support that you need. These are the men that also you can ask about the prostate form or prostate cancer in general. If anyone here would like to assist with our work and in turn learn more about prostate cancer, please see me or any of these board members. Tonight I have the pleasure of introducing to you Dr. Christopher Saigal. Dr. Saigal will speak about the latest imaging technology and how to make active surveillance a safe alternative to invasive treatments for prostate cancer. For more than a quarter of a century, transrectal ultrasound has been the standard imaging technique for systemic prostate biopsies. And we all know how uncomfortable and even painful that can be. However, modern MRI provides superior resolution that could substantially improve prostate cancer detection. The technique, which fuses MRI imaging and ultrasound, could revolutionize prostate cancer detection and supplant ultrasound-guided biopsies, which have been the standard, as I said, for 25 years. Targeted prostate biopsy with magnetic resonance imaging, MRI, tripled the cancer yield compared with conventional systemic biopsies. Tripled what regular systemic biopsies give. Tripled the results. This technique has potentially widespread applicability to prostate cancer detection and for monitoring men who opt for active surveillance of clinically low-risk prostate cancer in lieu of annual or semi-annual biopsies. Dr. Saigal is an associate professor and vice chair of the Department of Urology at UCLA. His surgical practice is at the Ronald Reagan Medical Center in Westwood. He serves the Department of Urology Director of Health Services Research, as well as the Director of Innovation. It is with great pleasure that the Prostate Forum of Orange County presents to you Dr. Christopher Saigal. We don't have our sound man today. He forgot about our meeting, so would the people in the back kindly move forward so Dr. Saigal doesn't have to yell too loud.
Well, thank you for the invitation. The chance to speak to you it means a lot to me. I myself actually had testicular cancer, so I struggle with some of the same choices about treatment and side effects that many of you have been dealing with or already dealt with. So I'm happy to be here. My research areas of interest are in decision making, and so today I want to talk to you a little bit about the role of MRI-guided biopsies in making better decisions in prostate cancer, both in terms of finding men who can be served by active surveillance, and also in finding tumors that matter, making the biopsy more effective. I'm going to start with an overview of the situation where we are today in prostate cancer. I'm sure many of you are very common with this. The most common non-cutaneous cancer in men. It's responsible for a great deal of suffering in this country, and it's very prevalent. Risk factors are age and race, potentially diet. As we look at people that move here from Japan and adopt our diet, we see an increase in prostate cancer risk in those that aren't native born from Japan. And certainly family history is important. If a first-degree male relative, a father or brother had prostate cancer before age 65, the man's at risk. One of the things about prostate cancer that's hopeful is that since the introduction of the PSA test, we have seen a real change in how prostate cancer shows up in our clinics. And this table shows how in the early era before PSA, a lot of men were showing up with these kinds of problems. These are T3 lesions, big rock-hard prostate glands. And as time progresses, the proportion of men who show up with those problems goes down, and the proportion of men who just have a normal feeling prostate and an elevated PSA and are probably more curable has gone up because of PSA testing. That's been a fantastic boon, I think, to men in this country and their wives. But a very famous urologic oncologist, Will Whitmore, asked many decades ago, is cure possible for those in whom it's necessary? And is it necessary for those in whom it's possible? That is, are we finding a lot of cancers that we're not actually helping the man by treating him? And how can we focus our efforts on finding those cancers that are going to really shorten someone's life? So in an effort to help men, we have created a whole plethora of treatment options for our patients. Surgery is both robotic and open, predominantly robotic these days. External beam radiation has many varieties. Brachytherapy, there are experimental treatments like HIFU and cryotherapy, and then the newest kid on the block is active surveillance. So I think if you've got a new diagnosis of prostate cancer, you have quite a broad spectrum of choices from which to choose, from watching things to having your prostate removed. And this can result in a variety of treatment patterns. So this is a graph showing, this is community-based data, so from practices all over the country, and it shows how, on the bottom here we have the aggressiveness score of the cancer. This is not very aggressive, this is most aggressive, and this is how men get treated. So the blue is surgery, the yellow is brachytherapy, it's kind of hard to see back there I think. The red is radiation, the brown is watchful waiting. So you can see that the men who have the lowest risk tumors, most of them are getting surgeries. And as you get more aggressive, fewer men get surgeries and more get radiation therapy, but even more get what's called primary androgen deprivation therapy. They get hormone shots just to start with no other therapy. That's not a curative process. And these are the guys who are at risk of dying of prostate cancer. So I think that part of the problem in our country is that we have a lot of guys getting overtreated with surgery, and not enough guys getting surgery or radiation therapy who need it, and we're getting ineffective hormone treatments that don't cure cancer. This is also a very busy slide. I'll summarize it. Essentially, this is a slide that shows that where you live really determines what kind of treatment you get. So each bar here is a different practice in this big national survey. And the numbers here show the mean aggressiveness scores of the cancers in that practice. So down here, there's two practices that have a very similar aggressiveness score. The men in that practice have very similar cancers. Yet in this practice, 81% are getting surgery. In this practice, only 16% are getting surgery, and the remainder are getting brachytherapy. So if you're a man going to this doctor's practice, you'll probably get one thing. If you go down the street, you'll get a completely different take on what to do. So there's clearly a problem in terms of the use of evidence to help men make a decision, I think, here. This is important for men because each of these treatments has very different impacts on quality of life. UCLA were basically pioneers in the measurement of quality of life and impact of prostate cancer treatment. This is a graph showing how we follow that kind of a thing. Usually you can score urinary quality of life, sexual quality of life, and bowel function quality of life on a graph and give a man a survey. And every 3 months ask him specific questions about how he's doing and track it. And then we scale up from 0 to 100. And 100 means you're doing pretty good. This is an example of what happens to men after surgery for prostate cancer. Right after surgery, their scores are low. They slowly increase over 2 years. After radiation therapy, the men start on the lower side because most of the men are older that get radiation therapy. But they also have a slow decline as the radiation can affect some of their nerves over time. And men have about the same, about 2 years. This is a similar graph for urinary function. So men after surgery have an immediate drop in terms of their quality of life related to urinary function. It kind of rises slowly over time and kind of meets up where they were for the men at the radiation therapy were in terms of their quality of life. And in terms of bowel, this is urinary bother. So this is how bothered you are. And it's good to know that basically by 2 years, both men having surgery and radiation therapy are about equally bothered. They're not perfect, but they're not terrible. So there's ways to try to mitigate these things when you do surgery. I'm sure all of you have heard about the robotics approach and a variety of different ways to do radiation therapy. They're all designed to try to minimize the impact of treatment. However, I think Dr. Whitmore's conundrum is still applicable. Who do we need to treat? And do we have to do, we can minimize the impact of the surgery using a robot, but do we have to do surgery at all to help that man? And this is where the role of active surveillance comes into play. So active surveillance is more than just watchful waiting, which is an older term. Watchful waiting was, a man comes into your clinic, he's got prostate cancer, he is perhaps 78 years old and has diabetes and high blood pressure, and you say, listen, we're not going to do anything, we're going to let you alone. If you begin having bone pain, you can't pee, we'll give you a Lupron. That's watchful waiting. Active surveillance is a whole different approach. It says you're perhaps a 60-year-old man, and you're otherwise healthy. You have a little bit of a low-risk prostate cancer, maybe a Gleason score of 6. We're going to follow you every 4 to 6 months with PSA testing and physical exam, and re-biopsy you periodically. And if things change, if your cancer becomes one of those aggressive ones, we're going to take action. So it's trying to delay the impact of treatment and not miss a window for a cure. And it's a relatively radical approach that has been more and more accepted in the last 10 years. Not everyone is a candidate for this. And I'd say that the data on most series on men having active surveillance is at about 7 years of maturity right now. There have been 7 large trials on this topic. And the men that are usually candidates for the trials are men who have Gleason 6 cancers, or some have Gleason 7 cancers in them. Your PSA is usually 10 or less at diagnosis. And on physical exam, if you can feel the cancer, you only feel it on half of the gland. In terms of tumor volume, you can't have a whole lot of tumors be positive, a biopsy report be positive. And lifestyle is important. If a man's willing and able to come in for regular visits, he's an appropriate candidate. If he's moving a lot, traveling a lot, can't do it, then it's not a good match. And in terms of how it works, as I mentioned, there's a PSA and prostate exam every 4 months for the first year typically. And we do a repeat biopsy at enrollment, which I'll discuss why that's important and how we use MRI to make that a safer practice. And we do one at 1 year and then usually at 2 years. Then we kind of go along with the PSA and the man's sort of general feeling about how often to repeat biopsy. And we move to active treatment, surgery or radiation therapy, for an increase in PSA, an increase in the Gleason score, or a change in the physical exam. And then, of course, for the patient preference, I don't want to do this anymore. There's no strict criteria for any of these. Different centers have different cutoffs. So is this a safe thing to do? So as I mentioned, the longest study is out 7 years, the shortest one's out 2 years. And the cancer-specific survival has been excellent, almost 100%. Very few people die under this protocol. And what's also important is that if you go under active surveillance and then you end up having treatment, your chance of being cured by that treatment is very similar to men that sought treatment at the get-go. There's one of these trials where that wasn't true. Men having surgery seem to have worse disease, but the survival impact hasn't been seen as that. So it's been, so far, so good. It's been a really successful approach. Now the question is, can we make that safer? And this is where the role of image-guided biopsy comes into play. So as those of you who've had a prostate biopsy know, we use ultrasound now to make this, typically, to make this diagnosis. And prostate cancer can appear on the ultrasound as hyperechoic as a white spot, as a black spot, or basically as similar in grayscale to the prostate in ultrasound. So because we can't really see it very well without even Doppler, we tend to do systematic biopsy. So we march through the gland with each arrow is a biopsy here, and we sample the gland where there usually is cancer, and we hope we hit it. So if it's a big tumor like this, we'll likely hit it. A small tumor like this, maybe not. And in fact, if a quarter of repeat biopsies in men are positive after your initial prostate biopsy. So MR fusion is a new approach to making this biopsy more accurate. An MRI machine is basically, it's a very large magnet. So you can't put a needle into that area to do a biopsy typically because you can't have metal in the room. But what we can do is take the image that we get on an MRI, which is incredibly detailed, and we can use what's called multiparametric MRI. So we can give the man various dyes and do special software analysis on the images to measure various parameters of the gland and get this special image down here. Down here. And then in real time, when the man's in the biopsy room, place the ultrasound probe and match that to what we see in ultrasound and essentially fuse these images to get the benefit of the MRI with the portability and ease of use of the ultrasound. And we can target the lesion. So you can see things in MRI that you can't see on ultrasound. This is how it works in the clinic. Basically, for those of you that have had a biopsy, this is the probe that we use in the rectum. And that probe has a sensor on it that's picked up by a generator that's put over the hip. And that sends information to the ultrasound machine that says, in 3 dimensions, where is this probe? And the computer then matches up the MRI, the ultrasound, and in real time we can see what's happening on the MRI. So in this way, we can actually target this specific lesion. And this is an example from a real a UCLA procedure I did recently. And you can see here, this bullseye is the target. We see it actually initially on the MRI. This is done in the radiology office before the man has his biopsy. They do all these special images. They identify this. They superimpose it on the ultrasound, so you can get right in there with your needle. And what's useful in terms of active surveillance is that the computer creates a 3-dimensional model of the prostate. So this is the prostate gland. The computer maps out the targets you're going to hit. This blue thing is what we saw was a cancer. It tells you definitely go here. And then after we hit this, if it's cancer, on repeat biopsies during active surveillance, we can hit the same target. A lot of times, in men who get active surveillance using ultrasound without MRI, when you repeat biopsy them, you find no cancer. Not because there is no cancer, but because you're essentially just missing the cancer, because you can't see it, and it's small. With this, you can survey that one special area where there's cancer, and if this changes in grade, you can take action. So you can be even more sure you're not missing something. The other way you can use this is, we have many folks that come to us from the UCLA after having a diagnosis of prostate cancer where it's a low-risk tumor and maybe they're suitable for active surveillance. When you do their MRI, you see well, maybe there's a bigger tumor somewhere in that gland. When we biopsy them, we find a higher risk tumor. So we then can exclude them from active surveillance. So it helps us to make sure that we're only putting men on active surveillance who have at least 6 or 7 cancers. So this is an important slide that tells us another benefit of using the MRI. Part of the issue is that you want to find significant prostate cancer when you biopsy. You don't really want to find too much Gleason 5 or 6 cancers because it creates anxiety in men. And if you find an older man who has a Gleason 6 cancer, all the evidence suggests maybe you're not helping him by finding it. It causes an anxiety, he shouldn't be treated. But with MRI, this is basically looking at the, when we do the MRIs, we give a number to each target. 2, 3, 4, 5. 5 means very likely to be cancer. 2 means not likely to be cancer. So when you look at these, we basically only biopsy scores of 4 or 5 on the MRI. So looking at that, most of the cancers found with the 5s are significant cancers. So that's a very helpful thing for us. We know we're getting the bad actors. But it's still important when you do the MRI guided biopsy to do the systematic biopsies because it's not a perfect technique. This slide shows you of our series at UCLA how many men had cancer found both on the targeted biopsy where the computers had to go and also on the regular type biopsies that are systematic. This shows you where only the target was positive. And when the target was positive, but the systematic biopsies weren't, we're finding significant cancers here. And then when we just look at the systematic biopsies, there's 15 men here with significant cancer who had a negative target biopsy. So we got to do both, I think, is the deal. So the other thing about this I think is it's important is that when you have all this information, when you're using the MR to make good decisions, how can you help the man take all this in and find out what's right for him? And one of my interests is in using software to help us do that. So one of the things we have at UCLA is a system called WiserCare. as you mentioned, I'm a co-founder of the company that makes this software, but it was inspired by men who have this problem. I want to help them make better choices. Basically, our men in our clinic, if you have prostate cancer, one of our assistants puts in your PSA, your Gleason score, your T-stage, a bit about yourself, and then you answer a series of questions that say, trade-off things like urinary control and sexual function. This one says, what if you were in a future where you had some leakage for 6 months, but you had normal sexual function? Would you choose that, or choose a situation in which you had no change in your urinary control, but had problems with sexual function? You pick one or the other, in a set of degrees. Answer about 15 or 16 questions like this, the system knows where your values are. At the end of that, you get a report to share with your doctor. And it's hard to see for you guys, but essentially, this rank orders of treatments that are available to you: radiation therapy, active surveillance, brachytherapy, surgery, in order of how they might best serve you in terms of your goals of survival and maximizing the quality of life. And it also tells the doctor what you find to be important. This man found sexual dysfunction and incontinence top of his list. Some men, it's all about their survival, and sexual function on the bottom. Who are you? It helps us to know when you sit down with us, we have a report, we can tell where you sit. So we're using this in clinic right now, and we've had significant increases in patient satisfaction for that. Another thing that I think is important to discuss regarding prostate cancer men who have low risk disease is the role of diet. And I'm not sure if you've all heard about this work that Dean Ornish at UCSF has been doing in terms of how men can help themselves when they have active surveillance stay off of treatment. This is a study where they randomized men who had prostate cancer and were on active surveillance to either usual care or a special diet and exercise. This diet was very Californian. Lots of tofu, fish oil, vitamin E, selenium, and very low-fat diet. And then also did exercise weekly, walking 30 minutes a day for 6 days a week. They did gentle yoga and meditation and stress reduction. And we looked to see, how are these men different? To me, it sounded unlikely to be useful. But what they found was that, and this is randomized data, in the control group, 6 men went on treatment. They had surgery, radiation, but no one in the lifestyle group did. And the PSA decreased in the experimental group and increased in the control group. A small amount, but it was significantly different. And what I think is most interesting is if you took the blood from the men who used this special diet and exercise, and you cultured prostate cancer cells in that blood, and compare that to men who had regular diets and their prostate cancers in their blood, the growth was slower in the men who had the healthier diets. So there's something happening when you change your cardiovascular profile that affects the growth of prostate cancer cells. So if you have a low-risk prostate cancer, if you're on active surveillance, there are things you can do to keep yourself healthy. Heart healthy, number one, because the number one killer of men with low-risk disease is heart disease. Number two, keep yourself away from the surgeon's knife or the radiotherapist, and have a better quality of life too. And one of the final things I want to talk about is the herbal medicine issues around prostate cancer treatment and low-risk disease. There's a very famous case in California around a drug called PC-Spez. This came out in the 90s. It was sold as a Chinese herb for prostate cancer treatment. And it really worked miracles. It reduced PSA in half. And then we noticed men began having more heart attacks, blood clots in their legs. And when it was analyzed, it was found out that basically it was estrogen. And it was being sold as a herbal medicine. And the manufacturers actually realized this, that it could cause heart attacks and blood clots. And then they added a blood thinner to it. So it was really a pharmaceutical, a very powerful pharmaceutical. So most of these things on the internet aren't regulated. It's really buyer beware. And there are some laboratories that do testing of online herbal medicines that you can go to. Consumer Reference Lab is one of them. They take these samples and analyze them and tell the consumer what's actually in them. But you definitely have got to be watchful, I think, on that. So just to conclude on this one, active surveillance is a safe strategy, I think, when done in a setting where the patient's compliant with coming into visits and the doctor knows about the protocol. The benefit is it allows a man to avoid the negatives of treatment, but preserves that option for the man. Imaging technology can make active surveillance safer. So MRI, guided fusion, before you begin active surveillance, can make sure you're not going to miss the aggressive prostate cancer. And immunotechnology can also make the diagnosis more accurate, find the more aggressive tumors, and hopefully avoid finding less aggressive tumors. And of course, the cancer treatment has to be individualized to the patient. And one of the things I'm doing for the research is I'm partnering on a grant with the CPCC, the California Prostate Cancer Coalition, and we're going to put in some decision aids in clinics where men are of lower incomes and education levels, and see if we can help them engage with the evidence and their preferences, and then make better decisions for themselves. So looking forward to, you said, partnering with the CPCC and hopefully other survivors in the state to improve the quality of decision making for prostate cancer care. Thank you.
We're going to have a little change of format here today because normally we have the microphones and we have you come up here. Since we don't have the microphones, you can stay in place and raise your hand and we'll identify you one at a time. So let's start out with Bill and then I'll be over to you, sir.
Okay,
Stand up, please.
many of us in this age group have kidney problems. Now this dye they put in, quite often dyes are really bad for your kidneys. So
Right.
what's the story on
With the MRI. So the dye that we use in MRI is called gadolinium, and it's safe for use in men that have elevated kidney function tests. If you have very high tests like dialysis level, there's a small risk of a condition called systemic fibrosis, but that's very, very rare. It really happens in men who are on dialysis.
Thank you.
Sure.
Yes, sir.
Yeah, my question was on a couple of slides back about the salt palmetto and Pygeum.
Uh-huh.
I didn't understand what that bullet was. Is
So-
it good or is it not good?
Oh, I see. So I didn't mention saw palmetto or Pygeum directly. I was talking about a different herbal medicine that was called PC Spez. It's not in the market anymore. Saw palmetto and Pygeum are used by men to improve their bladder emptying. It's sold for benign prostate hyperplasia. And I think what happens is it gets marketed as a prostate health pill. And so they don't say you shouldn't take it for prostate cancer. So then people are going to taking it thinking it's going to help their prostate. But it has no effect on prostate cancer.
Yes, sir. Go ahead, John.
Do you have an opinion as to the effectiveness of the fusion MRI versus ultrasound or ultrasound for targeted biopsy?
Right. Well, it's not been tested head to head, but I think when you look at the functional abilities you get with MRI, I think that it's going to be a much more sensitive technique, and a color Doppler is an advantage over regular ultrasound, that's for sure, but it still doesn't have the resolution of MRI, and I think it definitely doesn't have the ability to store the location of the tumor and call back up, year after year.
Yes, sir, Charles.
Yeah, I went to Dr. Bugman, who spoke here last year concerning the same subject. And he did an MRI, just a straight MRI, prostate MRI on me, and I did not see anything. And he advised me that before they could do a MRI-directed biopsy, that they would need for me to do a regular old-fashioned biopsy. Why is that?
That is a personal recommendation. For our patients at UCLA that have an elevated PSA, I'm basically moving them all towards MRI-guided biopsy. If I had an elevated PSA, that's what I would want.
I don't have an elevated. It's
Oh,
only
good.
from the 3.
Okay. But I think part of it is a concern for expense. It's definitely more expensive to do with the Square for Society. MRIs are expensive. So for a screening tool, are we going to go to that expense? I don't know. But right now, for my patients, I think it's better, so I do it. If a man had to pay out of pocket, then that becomes his personal choice as to how much that information is worth. Is it that much better to pay out of pocket?
Medicare covered?
It does cover it. But some patients don't have insurance or they have bad insurance.
Right over here.
I understood.
Stand up so we can hear you.
I understood from reading that soy is beneficial and vitamin D is beneficial, and that antioxidants, mushrooms, cruciferous vegetables are all positive as it pertains to cancer. And someone suggested to me that I take this extraction of a Japanese mushroom called a maitake mushroom, maitake D. So do you have any feeling about that one way or another?
Well, I'm not an expert at that, I gotta say. So, I've heard that people like Andrew Weil recommends mushrooms, and they have, some immune stimulating properties, but the science behind that is not clear to me. So, I guess it's, you've got to make your own decision on that. Sorry.
Yes, sir. Go ahead.
I was just wondering, does UCLA, have they done any studies about the cost effectiveness long-term of using MRI-guided biopsies versus not? Because even though an individual biopsy might be more expensive, I would think that perhaps in the long run, it might be more cost-effective to do all biopsies with the MRI guide.
Yeah, I mean, it might be, especially if you can more effectively assign people to treatment. But we haven't gone that far yet. I mean, this is relatively new technology. Only a few centers in the country have it. We have like a real prostate team. When we take a prostate out of someone's body, we then compare the whole mount prostate to the images that we had before surgery. So we're doing a very intensive data capture just to make our diagnosis more accurate. When we have that fine-tuned, then the next level will be basically, what is a good strategy for use of the technology. It might be effective as you say, but we haven't done that yet.
Go ahead.
I'm in a HMO, so I wouldn't qualify. So out of pocket expenses, what would it cost?
Oh, that's a big mystery at UCLA. I tell you, it's definitely a couple $1,000s, I would say. There's always negotiating and whatnot, but that's a tough situation when it's out of pocket. Then you really have to sort of figure out what's worth it.
Yes, sir.
Is UCLA the only place here in Southern California that has that technology?
Well, other places do prostate MRI, but I don't think there's anywhere around us that has the kind of team in terms of the coordination of the surgeon and the radiologist and pathologist that have been working on it. We had this Artemis machine is a first generation machine. We were the first to have that. Now we have a Philips machine. We have it, and NCI has it, and one other site has it in the country. So you can get MRIs done, but it's hard to get the fusion technology done.
Larry, I know you got another question.
Put 'em on the spot.
So, what is the software that enables the fusion? What is that software? Can you talk a little bit about it? How does it work with the fusion software?
Well, I'm not a software expert, but basically there's a few parameters that the software calculates. There's a diffusion, it measures the diffusion basically of water between the cells. And that's one thing that it does, and essentially cancer is more packed in tightly, and so water diffuses less slowly. The diffusion coefficient is a little lower. So it measures that for us. It measures the intensity of the contrast, how quickly it lights up and goes down. It gives a few signals to us, and then we can grade it. And how it actually merges the two images, that is a software engineer question.
Dr. Saigal, I have a basic question that I'm a little confused on terminology.
Sure.
Multi-parameter MRI versus MRI ultrasound fusion.
Okay. So all multiparametric MRI means is it's an MRI where you do these special things. Look at the diffusion, look at the intensity of the contrast going up and down, looking at more than one parameter, not just the picture, but the functional MRI data. And that multiparametric MRI is fused with the ultrasound. So to do a fusion biopsy, you've got to have a multiparametric MRI done.
So they're both. Okay, now the question before the board of directors here is this going to eventually take the place of the biopsy?
Well, it is a biopsy. So, I mean, it's basically an ultrasound-guided biopsy, the MRI. That is a question that's open in this era of healthcare reform, because it's certainly more expensive. And I think the comment about whether it's cost-effective will probably be very important in terms of its future. I mean, right now, we can offer it to patients without a whole lot of angst in terms of extra cost. But if that becomes an issue, then we'll have to really, then the middle of the road in terms of what people want to pay for.
So you're still going to have to stick the biopsy needle.
Yes, so just doing an MRI is not adequate in terms of, I mean, in the UK, there's a center that does a lot of MRI. They are starting to use MRI as a screening tool. So you get your MRI, if it's normal, then whatever your PSA is, you're not having a biopsy. So that is a vision that the technology is not there yet. Certainly, I've seen men who had normal MRIs and had prostate cancer and biopsies.
Let's take it one step further. So when you fuse it with the MRI, okay, there's actually a grid, okay? And the grid allows you to point where the cancer is if you have cancer. If you have a tumor, it appears in one of those grids. And the software tells the computer, and then the computer can guide the doctor in terms of where to.
Yeah, so you see where your needle's going to go, and then essentially you can make sure it goes to the target you're looking at.
Yes, sir.
So do you have an MRI first, and then you go away, and then you schedule
That's right.
the biopsy part, and that's
That's
what
right.
usually happens?
That's how it works. The MRI is happening at a separate time, gets analyzed, and then it's ported to the machine when it's time for the biopsy.
One more.
So would you just have, would it be a single, one core would be taken, or would they do the traditional?
So
They have to do specific areas?
we do basically both. The slide I showed that showed us like 15 men in our series had cancer only found in the systematic biopsy, and the target biopsy was negative for cancer. It was not a perfect test. It was better, but not perfect. So we still, when we're there, take systematic biopsies. We take a few cores out of the target.
Just to recap, you're not yet at the
Stand
point
up,
where
John, we can't hear you.
You're not yet at the point where you would do the MRI on someone that has an elevated PSA and you say, well, we don't see anything, so we're not going to do a biopsy. It's still going to do the
That's right. That's right.
Yes, sir.
Yeah, there have been several studies done that show correlation between Gleason score and MRI values.
Yeah.
How effective do you believe those are?
They're pretty good. If you have a 5, you're more likely to have a significant cancer. If your MRI image target is rated as a 5 out of on a 1 to 5 scale, you're definitely more likely to have a significant cancer. That's another way. It's sort of a smarter biopsy in that way. If you don't biopsy the ones that are graded 1, 2, and 3, and only go for the 4s and 5s, you're more likely to find aggressive cancers, as opposed to just finding Gleason 6 cancer, which for some men shouldn't be found because they're not going to kill them.
Yes, sir, Charles. Stand up, please, so we can hear you.
What you were saying about the doing just a regular MRI as a guide before you do the MRI with the biopsy?
You do the MRI first, and
Yeah.
that image is then saved.
Yeah, I understand.
Okay.
They did that on me, and then the doctor told me that it didn't show anything, so he didn't advise me to go and have an MRI biopsy.
Sure. If the MRI doesn't show a target, then there's no point in using it.
Yes, sir.
I just wondering, it just occurred to me, I wonder if any of the tests like PCA3 or the free PSA and other tests like that, is it advisable to do a series of those kind of tests before the MRI is done? Is that kind of combined with the MRI to be more helpful?
Yeah, I mean, all those they're all complementary bits of information. If your PCA3 is positive, you have a target on your MRI. I mean, it definitely can make you want to go through with a biopsy for sure. Whereas if your MRI shows a number 3 lesion and your PCA3 is negative, mitigates against doing anything in terms of tissue diagnosis.
Yes, sir.
I'm on active surveillance and I've had 4 biopsies. They missed it on the 3rd one, like you said. But I'd like to go back to the slide on your diet.
Oh, sure.
And then a comment like, I take Lipitor, not a huge amount, but like in the New York Times yesterday, now they think that any statin may hurt your exercise program in the sense that you can maintain yourself, but you can't necessarily gain muscle tissue, right? So I've been thinking about just getting rid of the Lipitor and staying strictly on a diet like that, but then I've also heard from some of the experts that Lipitor helps maybe retard the cancer.
Yeah, there is some data about that, about statin use and slowing the growth of prostate cancer and also kidney cancer. So I don't think it's going to impact your muscle mass that much. And I think I would probably stay on it if I were you, given what it does to prostate cancer. But I would also encourage you to, eat as hard a diet as you can. I'm not a huge fan of taking supplements like vitamin E or selenium or vitamin C. I think it's better to get them out of the food you eat. So I think food's very complex, and taking one thing out and having high quantities of it can be counterproductive. In fact, vitamin E can cause cancer in high doses in smokers, for example.
Okay. I thought vitamin D was on the list.
Vitamin D is another one of these things where there's been a huge push to increase people taking vitamin D. I just don't, personally, I don't believe that the science is there. I don't believe that it's better just get out of your regular food.
Larry? I knew I couldn't keep him quiet.
The gentleman that talked about exercise and the cholesterol agent inhibitor, I've worked out for 30 years, and I've taken Zocor R, the drug that you mentioned, and I don't find that it impacts muscle mass. As a matter of fact, if I work out real heavy, I'll gain muscle, so I back off of working real heavy.
Well, I wonder if the doctor is familiar with that New York Times story.
I didn't read it, actually.
Okay.
I didn't read it.
Yeah, but I do know that there is some evidence that cholesterol drugs does have a ability to positively affect prostate cancer. There's some evidence.
Yes, sir.
As far as the cholesterol, statins we're talking about, example right here, I can take it, I have no problem at all. My wife took it, tried to put it in the hospital.
Oh, yeah.
Here's just two examples.
Yeah, what can cause myositis and muscle aches, quite serious. Yeah.
And then one more. What about, since I've had 4 biopsies, what if you go to your urologist and say, this time I'd like to go to UCLA and have the next biopsy, right? Is there kind of a jealousy or anything? Are you losing anything there?
Well, listen, I'm sure your current urologist likes to see you and knows you, and that's a valuable thing, I think. If I was in active surveillance, I would want that same tumor targeted every time. And I don't think that's, it's like personal with your current doctor, and you can still see him, but you're just going for a specific technology. I think it's reasonable given what we're talking about.
Well, I think you've just about exhausted the audience here, Dr.
Okay.
Saigal. As I mentioned to you before, we never pay these doctors here, unfortunately, because we don't have that big a budget. But how long did it take you to drive here?
3 hours.
3 hours.
Yeah. Traffic was unbelievable.
I'm sorry, I didn't mean to bring that up. Anyway, we know that doctor's time is money. So we can't give him the hard green. But what we'll do is give him this coffee cup that he can sit in his car so he doesn't have to sit at home and drink his coffee. He can drink it on the road.
Great, thank you.
Thank you very much.